I should also know that off the top of my head. You guys normally do.
Yeah, it was kind of unusual, but I think that we didn't, is my recollection.
You did not.
Okay. So we need to approve minutes from February and April. Is that right?
Yes, ma'am.
Yeah. Okay, thanks.
And it's not quite 2 o'clock and the waiting room is still kind of clearing out. So we'll give it just a second before we get started.
Great. Hi, Arthur. Good to see you.
Arthur said he don't think you'll be able to meet. You wouldn't be able. You wouldn't be able. You weren't able to meet last time.
Yeah.
Did you catch that?
That Arthur was sorry that he couldn't meet last time.
Yeah.
Right. Okay. Yeah, I understand, Arthur. I think you weren't feeling well and that happened. So I'm glad to see you here today.
Hello.
Hi, Melanie. Good to see you. I was looking back at some minutes. I wanted to make sure I had the right thing pulled up.
Oh, and I'm sitting in my car outside of a pool, so please forgive me. I'm with my son, so
Well, that sounds like a fun day. I'm glad you can join us.
Emily, it's 2 o'clock and your waiting room is cleared if you would like to begin. I saw everyone but you and Christy, but I'll scan just to make sure I didn't miss her coming in with a big group.
So is Miranda on as well?
Yes.
Oh, great. Hey, Miranda. Oh, now I see you. Good. I'm glad this time ended up working for everybody. Thank you for helping us find a time to reschedule. And I'm just taking a couple notes. It's nice to see everybody. Happy July.
happy July.
I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health and the Chair of the Consumer TAC. And I'll just ask all of our members to briefly introduce yourself. Brenda, Arthur, Melanie, and Miranda.
Hi, I'm Brenda Menino. I am representing AARP.
Say he is Arthur Campbell. He is he's working. Give me a second, guys. Oh, representing. He says his name is Arthur Campbell and he's representing PNA.
Great, thank you. Melanie and Miranda.
I'm Melanie Tyner Wilson, and I'm representing the ARC of Kentucky.
Hi, I'm Miranda Brown, and I am representing Kentucky Equal Justice Center.
All right. We do have a quorum present, so we can conduct business and vote. The first order of business is to approve minutes, and we'll need to approve our minutes from February and as well as April. We didn't have a quorum at our last meeting, so we weren't able to approve February. So I'll take a motion to approve our minutes.
I move to approve the. Oh, sorry. Sorry.
A second?
I second.
All right, thank you, Brenda. All in favor, say aye.
Aye.
Aye. Any opposed? All right. Motion carries. Our minutes are approved. Thank you all. And the next item here is our old business, just topics that we've discussed on previous calls. We're looking for updates. The first is always our standing data requests. So is someone on from DMS who can tell us about enrollment in our various types of Medicaid coverage?
Yes, good afternoon. This is Jordan Griffin with DMS, and I can present some of the numbers as far as our current enrollments. So for presumptive eligibility, these are as of July 1st. For presumptive eligibility, we have 1,677 individuals. For emergency time limited Medicaid, we have 176 individuals currently. In traditional Medicaid, we have 145,696 individuals. In our MCO, we have 1,303,955 individuals. The current enrollment is sitting at 1,449,651.
All right, thank you. That's really helpful. And that is a pretty big dip in enrollment from about a year ago, but we also expected some of that because of Medicaid renewals, which is, of course, the next question here, the next data request. Can you just kind of give us a sense of how many adults have completed the unwinding renewal process? I know all of, as far as I understand, the process has at least started for all adults, but there may be some that are kind of pending or awaiting some further action.
Hey, Emily, it's Veronica, Judy Cecil with Medicaid. Good to see
you,
everyone. I'll take this one, Jordan.
Okay.
So I will say over the course of the entire unwinding, we had 1,037,363 individuals go through a renewal. Whoa, right? That's a lot of people. We still have about 15% of those that are in one way or another making their way through the extensions or pending cases. So there's still a bucket of folks that we call the public health emergency unwinding renewals. That's that first renewal post the end of the public health emergency. So about 15% of those are still sort of kind of going through the flexibilities and maybe extended.
And those are all adults, right?
That's right. Mm-hmm. Yep. Yeah. A total of across the unwinding renewals, 74% of those were approved, which I think is amazing as well. And then, unfortunately, over 60% of the terminations were for procedural reasons. So, those are folks that weren't actually determined ineligible. They just didn't respond to the notice. I will say, so we're working on the June renewals. We just closed those. And I do want to note that in May and June, we had a little bit of a higher number of terminations and related to procedural terminations. And the reason for that is because, just to remind folks, we reinstated, about 25,000 people as part of the APTC advanced premium tax credit, cascading those folks to that eligibility and terminating their Medicaid. Just a reminder, we reinstated a lot of those folks to give them coverage and then put them through another renewal. And we found out is in May, about 11,000 of those procedural terminations, it's a large number of them are those individuals. They still did not respond. And so they've been terminated because of lack of response. We're seeing, although we're still evaluating, we're going to have a large number of those in June as well. The majority of those are going to be due to the reinstated individuals not responding to that renewal. So, again, and I think as you mentioned, as we're rolling out of that first round of renewals. And so kind of the tail end of that unwinding, we're seeing, a little bit larger number of terminations happening as a result of that. The other thing I just want to alert folks to is, so now in May, we had a mix of PHE first renewals, and now we're into second renewals. So we're now going to bucket starting May, June, July, and as we move forward, all the numbers are kind of going to be reported together at a high number. We're still tracking the PHE renewals, but in reporting the renewals, we're just going to shift because we know that this has been really informative for folks to know what's the status of renewals. So we're going to keep reporting. CMS is also requiring us to still report, but we're going to keep that going and reporting all renewals as we emerge out of the unwinding.
I think that's really helpful because
Yeah.
renewals do happen on an annual basis for folks.
That's right.
So, even though we kind of there was more attention to the whole process with the unwinding, it certainly is going to be ongoing. And I think it's good to really be looking at the eligibility versus procedural reasons. And hopefully we can learn something and make some adjustments in how we communicate or how people are able to participate in that process and over time have less churn.
Yeah, that's our goal as well. And one of the reasons we want to continue to highlight them in the efforts. We are right now evaluating all of the flexibilities we put into place and how effective they were. And so that's something else we're going to take away. Alterum is doing that evaluation for us, and we want to take away and really emphasize those, and ask for maybe some permanency to some of those flexibilities that have been effective. And with the final rule, and I know that's on the agenda later, but with the eligibility enrollment final rule, there are some that are, being implemented permanently, and we're really happy to see that. But going forward, like I said, we're going to start kind of just reporting all PHE and non-PHE renewals. The only other thing to note for starting in May, people that actually enrolled for the first time in Medicaid, so they're going through a first renewal because they enrolled in May of 2023. And so they're going through a renewal. So starting in May and as we move forward are brand new people going through a renewal too. So not just folks that have been in Medicaid for a long time and we had paused the renewal, but there's some that are going through new renewals. So again, outreach and education and keeping people aware is a goal of ours, and we're going to keep highlighting it.
Right. Thanks for those updates.
Emily, can I ask a question? And I actually had two. I wasn't quite sure what the PAG, I think that's what the initials were. And then if any of the terminations were due to people that maybe were, for whatever reason, homeless, like maybe there was an address and then they no longer had a place of residence for whatever reason. Would that be a possibility?
Yeah, thanks for those questions, Melanie. So for the first question, it's Advanced Premium Tax Credit, APTC.
Oh,
yeah, and we had starting in May of 2023, when our system would go out and try to verify eligibility with our trusted data sources, and we were getting information that came back to say that their income was over Medicaid, but they were eligible for that premium assistance. We were cascading them down to that eligibility and terminating Medicaid. Your second question, I think homeless is always a struggle, the homeless population and reaching them. We've got a lot of different outreach efforts around that population, trying to find ways to provide an address or a responsible person that can get sent to. And then again, our providers have been extremely helpful as people present for services. And having the providers interact and let them know that maybe they're either up for renewal because they can see the renewal date, or if they've been terminated, help them get connected to getting their coverage reinstated. So yeah, we do struggle with that population.
Okay, thank
Um,
you.
Emily, can I ask a question?
Yeah, absolutely.
I wanted to have that number again about how many Kentuckians are currently covered under Medicaid with all the different categories. What was the total?
Yep,
Sorry.
Jordan.
Yeah, so for as of July 1st, the total enrollment was 1,449,651.
Okay, thank you. And I think Veronica was saying some acronym that starts with a P, and I have no idea what that means. PHE or P something?
It's that, well, so PHE is the public health emergency.
Okay,
And I saw Miranda put the that in
Thank you.
the chat for folks. Thank you.
okay, thank you.
Yeah, absolutely.
Yeah, I think this is all good information to have. And, you know, I think as we move forward, if there's communications, you know, educational materials, flyers that we can help to review, that would certainly be something that the consumer TAC can do. And I'm curious to see if the enrollment bounces up a little bit. It did really dip, more so than in other months, like you said.
Yeah.
But this is basically back to pre-pandemic.
Oh, we're
About right?
we're about 100,000 or a little over 100,000 more than pre-pandemic. But I will also say that, you know, as we track Medicaid termination, we are at an extremely high number of enrollments in qualified health plans. So we hit 81,000, which is a huge increase. And we're seeing that stay steady and continue to increase. So as we do think that folks who are ineligible for Medicaid are moving over and actually enrolling in a qualified health plan, which is fabulous because we want to keep people covered.
This is a full 20,000 or more than pre-pandemic as far as the QHP enrollment. So we're still small. We're not the solution for everyone. We're a solution. If we're a marketplace, we're kind of a boutique. We will
I
never
think
have
81,000 is about what we had in 2014, if I remember it. I mean, we saw it, you know, it's kind of the inverse.
when we got decommissioned and sent on over to the feds, we dropped from 100,000 to around 81,000, and then it's been a steady decline ever since. And so we're clawing our way back there. So it's really, really encouraging. Those people who are in transition, those people between jobs, the pre-retirees. I want to be a pre-retiree anyway. People who have lost Medicaid to catch them and move them on. So we're already at 81,300 this morning. So, you know, second of the month, we should break 82, 83. I'm hoping that we help 100,000 people this year total. Because these are the active enrollments and we constantly have churn. So something good is happening, and thank you all to everyone on the call for all the hard work you're doing, because it surely isn't anything I'm doing. So appreciate it.
Yeah, thank you, David. And this is not a question that I had intended to ask, but I've been, you know, thinking about the implementation of the Omnibus bill, of course, which passed during the legislative session, and specifically the SEP, the special enrollment period for pregnancy.
Yep.
Have you been able to estimate about how many pregnant people will likely be eligible for that SEP?
No, but a very educated guess, small.
Yeah.
Most Kentuckians, when they become pregnant, become eligible for K-CHIP or Medicaid, which is great, or are already enrolled through ESI, the military, whatever it might be. So if we're a small group, this is an even smaller group. But the great news is it goes backwards to any time during the person's pregnancy.
Right.
Now, beginning January 1st, this year we won't go around the corner, but in future years, you could even enroll in a planned year before it existed for a November or December pregnancy.
But it really does fill a gap for those lower.
It does. It's so exciting.
Are just over the line for, you know, that K-CHIP 218%.
And hopefully that will mean that there's no pregnant people who are not covered.
Right.
It should be the last of it. And DACA, of course, is coming up as well. So it's Lots of exciting news on our side of the house.
Well, thanks for those updates. Does anybody have any questions for Veronica or for David?
I have one more update. There was a question that I saw is on the agenda, nothing about the looking for connectors who speak foreign languages. The good news is the search engine is working. The bad news is we don't have a lot of connectors who speak foreign languages right now. We're working on that from every side that we can, but the search engine does work. There's just not a lot of people there right now.
Hi, David. So, I mean, which search engine? Because on the public facing Connect website, if you go to find a connector or agent, there's no place to enter in language.
Yeah, there is.
Not at the link that I am currently at.
Okay.
Are you able to share your screen? Are we able to do that? Share screen? Or that's that
Yeah,
works?
who wants to do it?
Sharing the link. The link is fine. It looks like Miranda's already dropped it in the chat.
Right in the chat, you said? Okay, so Miranda hit like find connector on that screen. And then hit search, don't put anything in there. And you're searching for. Oh, yeah, here we go. Yay.
Can you see it now? Sorry,
I
my
can,
screen
yes.
was.
Yeah,
okay.
perfectly.
Thanks,
So now
Eric.
scrolling down and hit find a connector. And hit search. No, don't put anything in there. Hit search, please.
So are you saying that information comes up when you search, but
When you
don't
search, then at the
for
bottom, you can pick language. You can scroll down a little bit. Yep, there they are, languages.
see.
So, for unfortunately for contracted, non-private, we have only someone who speaks German. If you selected German, we could find Priscilla. If you on the qualifications, if you chose for private and public or facility-based and public, whichever one you could find yourself, Miranda, okay, in Spanish. So this is where you go.
Can you select Spanish just out of curiosity? I want to see, because I feel like it should be Miranda and maybe Soraya too from.
Oh, yeah. I
KJC,
was
but,
trying to be.
I'm just curious to see if there's anything else there. Spanish.
It's at the very top.
Spanish was at the top.
Yeah.
Okay,
Spanish was
thank
at the
you.
top. It's not in alpha order. I just realized that. No, that was
I was
confusing.
starting
It's
to think I
alpha
couldn't
order
spell
except for
today.
Spanish. Alpha order
English and
except for
Spanish are at the top. Yeah.
And then on the qualifications, you have to choose public or whatever it is.
Oh, you
And
have to.
private and facility-based, both of them. We don't have any that are public right now. So he's 0. I'll go back to qualifications if you don't mind.
Oh, did it?
And then facility-based.
What does facility-based mean to people?
Private.
I
It
mean,
used to
different-
say
I mean, like-
private, and what people would do is everyone wants a private connector. And so our brothers and sisters in the hospitals were getting inundated with requests from people.
Well, I would
don't
have put
know.
hospital connector then. Public and facility-based doesn't, from a public viewpoint,
Yeah.
I'm not sure if that would help. And then I don't consider Miranda and Soraya working at a facility-based, but maybe you all did want to, some limits on who was reaching out to you. I wonder if this is, if people will be able to understand how to make that, the right selections. Miranda, do you have any suggestions on how that could work better?
Thank
I
you.
mean, we have
for
around
walking-
120 connectors who are like contracted, and then hundreds more that work in various facilities. Some of them are in hospitals, some of them are in clinics and other things. So
Yeah.
we're always open to suggestions if there's a better way to go back to the different methods or whatever. So
So I really appreciate, like, this is a huge step forward. Like, I really appreciate that now connectors are able to enter that they speak more than one language on their end, and then the consumers are able to search for it. But there are definitely more connectors that speak Spanish than just Soraya and me. And so I think a lot of connectors still don't know that they can enter and that they speak more than one language, because there should be at least a handful more on this page, if not many.
No, that's good to know. And always when we know what we don't know, and for me, that's a lot. We now have monthly, not only meeting with all of our org admin heads, but I call it the all hands meeting. We also have a monthly meeting with any connector out there who wants to come meet with us. And so this sounds like a great topic for that. And I think we may not have a one pager. We'll definitely put it in this Friday packs as well. So then if people think they speak Spanish and don't know how to make it so here, they can reach out to us if we walk them through it.
Yeah, I know there are connectors at Health First Bluegrass that speak Spanish, and probably others. So yeah, spreading the word, I think, would be really helpful. Thank you.
That's a fabulous point. And at any times, people out there, if you see something on our website or whatever that is confusing or could be worded better or anything like that, we're always open, which we try to be.
So David, you said that there's going to be a work group meeting in which
every month.
Oh,
every month we meet with every single connector who wants to join us.
So this could be added to the agenda so that
it will absolutely be added to the agenda to make sure there's an understanding, and then when there's not, we'll get corrective measures out.
Okay, I think that would be helpful.
Yeah.
Awesome.
All
right. So I think if anything else about that, Miranda? Just looking at the agenda, we always have one other standing data request, which is around Kentuckians who received the 1915C waiver services. And we want to know who's on a waiver right now and also who's on the waiting list.
Hi, Emily. It's Leslie. I'm going to report on that if that's okay.
Hey, Leslie.
Let's see. So, and I tried, as you're aware, our numbers are kind of fluid. So I tried to get you the most current numbers I could. So we've got a total of 30,547 in slots filled. And I have those breakouts if you want those as well. And then on the waiting list, I have HCB at 1980. Michelle P. waiver is at 9142. And SCL is 3530. So that's a total of 14,652 that are on waiting list. And last time we did some calculations just to see like who was on the waiting list, approximately 40% of those are in other waivers, but they're on waiting list too. So if that stays constant with what we've got now, then that should be about 40% or 5860 that are receiving services and other waivers.
Thanks for those updates. Any questions about the waiver, either the slots or the waiting lists?
This is Melanie, and I think that with the allocation that was included in House Bill 6, but there were several additional slots, but that won't come into play until October. Is that right?
We're currently looking at slot allocation. If you can give me a short period of time, I will let you know where we are with that.
Oh, okay.
Currently looking now in the approved waivers.
Can you share a little bit about your process, Leslie, and also how, I know there's a report that's due to the legislature in terms of how people will be, is it assessed for the slots?
Yeah, and we have a meeting to discuss that, Emily, if that's okay. Let me wait. We actually have a meeting to discuss that language and the time period that needs to occur, if that's okay.
Okay, so we do have, because we had to reschedule our TAC meeting from June to July, we have another standing meeting in August, so we can put this on the agenda.
Absolutely. Thank you, Emily. Appreciate it.
All right, thanks. anything else about those slots? All right, so then we do have, this is kind of an awkward back and forth, but we have an item here about Medicaid renewals. So everything that we talked about before was related to adult renewals because the state got permission from CMS to wait on starting the child renewal process, which I think was really helpful for a number of reasons. But at some point, children's coverage will need to be renewed. So just wondering if you could give us any updates on that timeline and what that process will look like.
We are still waiting on CMS to get back with us. But what we did end up doing is maintaining the flexibility until we're told otherwise. We did have, we're going back and looking because in May and June, we did have some terminations. And so we're checking those to determine the reason and ensure the appropriateness of it. Because, children could still terminate, but we had a larger number. So we are going back. And if it turns out that a child was inappropriately terminated, we'll reinstate. But we are maintaining the flexibility.
I'm glad you mentioned that because of course we'd heard a few of those cases. Are you seeing any themes, anything in common?
No, we're digging into it. I don't really, I can't really speak yet to what we're seeing because we're still going back and forth asking questions.
All right. Thanks for that. And then as far as what we've learned from adult renewals and coming into child renewals, is there anything that you're going to be doing differently?
Well, no, our flexibilities are going to remain the same.
I just mean more like lessons learned, like just improvements that have been, yeah.
I see. That's what we're evaluating, is to try to see, how effective things are. And I know this is on somewhere else, but and I apologize, I do have to jump at 3. But if I could go ahead and talk to the surveys. So we had surveys out in the field. Is it okay if I go ahead and talk about that?
Can I just bring up one other thing about child?
Yeah, of course.
And then we can go to surveys.
Yep.
So one thing that we've raised from time to time is the request for birth certificates, which I don't think is a requirement by any means, for the Medicaid application, but there are times when people will get an RFI and children specifically will get an RFI for a birth certificate. And when it is most confusing to me is when that child has been born in Kentucky and even covered by Medicaid at a hospital. So like there's even claims data to prove that, they made their way into the world here in Kentucky. But we also know that the Office for Vital Statistics is within the Cabinet for Health and Family Services. I had a good conversation with Commissioner Lee about this recently, and her interpretation too was that we should be able to get it directly from the Office for Vital Statistics. So what I'm wondering is there something between DMS, DCBS, and the Office for Vital Statistics where there's sometimes, just wires crossed, miscommunication? But we are seeing these RFIs, and that's just one small example of something that I think if we could kind of nip that in the bud before we start child renewals, make sure that's never going to be a reason that a kid wouldn't, have their renewal approved. And not an RFI that a family would have to respond to and, get a copy of that birth certificate, pay money for it, mail it in, all of that. I think that's just one way that we could kind of simplify this and make sure kids aren't losing coverage.
Yeah, we're happy to take that back. I know Jordan's on. We can look into that a little bit more. There is a lag in the data that comes from Vital Statistics into the integrated eligibility system. So that might be creating some of the problem, because I don't think it's real time. So but let us take us back and dig into it.
All right, thank you.
Yeah.
But let's jump down now to the surveys if you want to share those updates next.
Yeah, just an update. So we still have some in the field, especially the Spanish version. And Alterum right now is going through the data. So I don't have the the responses or really any information to share yet. But and then the other thing that we're doing is we're gonna send out, we know we're missing folks. We really wanted the member to be contacted through the information that we have and directly from us so that we could verify that the member is actually doing the response. But we are going to send out another kind of shorter survey because we think we're missing some folks, and we want to be able to get it out there more publicly to give an opportunity for members to provide. And then that also means members that have lost eligibility. So we're about to go through that and get that out probably in the next week or so to give a little bit additional time, because we want information that we can use. And I think we're concerned that we don't have enough.
I think it's a smart strategy to wrap that around if you haven't gotten as many responses as you were hoping for. And I'm assuming this is something that we can all help promote.
Oh, yes, absolutely.
Okay.
We hope you will. Yes.
Yes. Okay, great. Yep. Happy to do that.
Great.
And the Spanish survey is also in the field, right?
It is in the field. Yeah.
Okay, great. Anything else about that before we move on?
No, so sorry, I don't have really numbers for you yet, but we absolutely plan to do a presentation on it when we have more information that we can share.
Okay, that sounds really nice. We'll look forward to it. Let's see, if we hop back up, I think we skipped HCBS waivers and rate study. Is that something that Leslie, you can give us an update on?
Yeah, one thing I was gonna do is just the PDS rate increase, just that, that sentence there. I was just gonna go back and just remind everybody that participant has the right to increase their PDS employees' pay up to the maximum reimbursement. Discussions about pay increases, of course, should not involve the employee. This should come from the participants and the PDS representatives, and that's not gonna mean that everybody is going to get an increase in pay. Pay must or needs to be able to depend upon years of experience, additional training, specialties, and other factors and things like that. As far as the corrective action plan, we have not received anything back from CMS, but we will gladly share when we get that, Emily.
Okay, thanks. Is that something, when you say nothing back from CMS, is that in what you've proposed to CMS?
Yes, so as soon as I get some information back on that, I'll let you know.
Okay, thanks. Arthur or anyone, any other TAC member, do you have questions about this? Is the rate increase something that you want to keep on the agenda, Arthur? Is there anything more specific in terms of the rate increase that you're interested in knowing about when we have these meetings every other month?
You will keep. He said he will keep. He said he will keep it on.
Okay.
And if we don't have anything, we can. Skip.
Skip it.
Oh, we can skip. We can skip over it.
Okay, yeah. I'm happy to keep it on here. I just want to make sure that we're not missing any, specific requests that you want to make for more information. So, and it sounds like we might have.
You say you do? He said he does, but he has to write it out.
Okay, yep. We can do that for the August agenda, Arthur. Okay.
And Emily, this is Melanie. The one thing that recently came out, which I thought was exciting from CMS, is that 80 or 85% of the new rate, it needs to go to the directly to the individual that provides the direct service. So
80%, right?
yeah, I think that's a really very positive move in terms of the workforce in our state.
Yes. I think what if I'm understanding this right, I don't know if DMS is able to track, or if they do keep track of how many waiver participants are using PDS and what they are paying their employees more specifically. Is that right? Leslie, do you collect information on what rates PDS employees are being paid?
So I'll have to double check. So of course, I can tell you how many people get or utilize PDS services fairly easily. There might be a way to see what they're paying. We would have to go into probably each individualized plan, which that's not probably feasible, but I might, I'll ask
Even
about
as
that.
maybe
Might
a
be a thing.
spot check. And
Yeah.
I'm just curious, like if the rule is that you have to pay 80% directly to the employee, then how is that being sort of monitored and enforced?
Hang on.
Is it
Alicia's
just somebody
chiming in
complains,
too.
or is there?
Sorry, I saw that Alicia was chiming in the chat.
Oh, I didn't notice it.
I'm sorry.
Sorry, I was just gonna say.
Yes, thank you, Alicia.
Can you all hear me?
Yeah.
Okay, sorry, I had my microphone up above my head. So the 85% or whatever, that would be traditional providers. So when a PDS employee has a contract, that total amount, would go through to them. Whereas with the traditional, they do have overhead and stuff like that. So just wanted to make that distinction there.
Right, okay. So the rule changes at risk, through Friday's SCOTUS ruling, the Supreme Court. Can you explain a little bit more about that, Justin?
Yes, about the SCOTUS or the implementation?
Well, I guess both, perhaps. Yeah, both.
Well, it doesn't initially block the ruling, but it leaves it open to being blocked by judges very easily.
Are we talking about the Chevron ruling?
Yes.
Yeah, okay, which really limits administrative, the authority of the executive branch.
And I'm not very clear on the second portion of what I wrote. I had spoken to a couple of the provider associations who were saying that the 85% as written in the access rule does not implement as clearly as it's saying on paper. I'd have to get back to you to kind of explain more, though.
Okay, that would be great. Thank you.
Of course.
All right, anything else related to that before we move on? Our next item here is the 1915I and 1115C waivers for supported housing and employment for people with SMI with serious mental illness.
I can give you a little bit of update, Emily. We've got on the 1915I, which is a state plan amendment. I keep reminding everybody. So the 1915I is a state plan amendment, and we had received an informal request for information, and we have turned that around and sent it back to CMS on 6/28. We are currently in informal, and I'd like to keep us there. Once you get to formal, it takes longer to go back and forth. So I kind of feel like this is the best time for us to be in our negotiation phase with CMS to get it approved quicker. So our informal will end on September the 3rd. So that's kind of where we are with that. So very excited. On our companion SMI side, we have an 1115 waiver for SMI, and it had increased days of stay for IMD, not to be more than 30 days average stay in Kentucky. And then we have the recuperative care piece, which we're very excited about. that allows somebody a safe place to heal before or after a surgery or a medical procedure. Those that are homeless don't have to go back to the street. We can provide them with a place to stay. So recuperative care will also be in that one. The 1115 SMI, we are hoping that it will be approved by CMS by September the 30th, which they are trying to align all of our 1115s to one so that our budget neutrality and all of our reporting, all of our quality measures, we call them standard terms and conditions on that side, but all those will be more aligned. So we are hoping to have approval by September the 30th. If it's approved on September the 30th, remember 1115s are different. That's a demonstration, and we have to have 90 to 120 days to write an implementation plan that they approve. And also we have to do a monitoring plan for them, and as well as get set up for the standard terms and conditions that they have requested. Some of those will be state specific and others will be specific to what CMS requires of us.
Okay, that's good to know. And I don't know why I keep putting the C.
No, everybody, it's fine. It's fine.
I think it's
Totally
because
fine.
right above it is the 1915 Cs. But anyway,
Totally
yeah, not to
fine.
confuse everybody. Thanks for clarifying all that. Any questions there? It's good to hear that you might, I mean, assuming that there's no other request for information, you're expecting a decision from CMS by
Yes.
September 30th.
Yeah, on the 1115. Now I could actually get a date quicker on the 1915.
On the spa. Okay.
I've been trying to really figure out, I want to make sure, if you remember, these are companions to each other, and for the full continuum, you know, and folks have to get used to it and they have to trust the process, and we have to get providers on. I'm trying to figure out like how we really want to roll that out, because the 1115 side will take a tad bit longer. It will take a tad bit longer because there's all these other requirements as a demonstration. The implementation plan, that's a 90 to 120 days, right? Just that. So trying to figure out how all that's going to roll out. But yeah, we're very excited. We're thinking we're getting close to approvals for both of them.
Okay. Are you considering an advisory structure like you've done, like you're currently doing for acres, what I like to call it the reentry waiver? I know it's got a longer name, but
that's fine. Yeah, we've discussed it. I don't know if it'll quite look like reentries, because reentries is so intense with the reinvestment plan and all the pieces that are even outside of our cabinet with DOC and DJJ and all of our sister agencies. Right. There's a lot. That's the biggest. I think it's going to be the most complex 1115 we've probably worked on in quite some time. Now, with that being said, I think the 1915I is pretty complex in itself as well, because we've given a full range or scope of needed services. So that's what I was talking about with the continuum. I think any decisions we make, I want to make sure that it flows out to the public. We communicate. We have plenty of time to communicate with everybody, build provider capacity if needed. I just want it to be smooth and for everybody to trust the process.
All right. Thanks for those updates. And we'll hope that you hear by September 30th, if not sooner. Everybody's been eagerly anticipating that news for sure. So the next thing we have here is the end of Appendix K for the HCBS waivers, which is probably something you'll be able to update us on as well.
As far as, and I was looking at that sentence, the end of Appendix K for HCBS.
The flexibilities, I should have
the
said.
Appendix K ended April the 30th, and then the new waivers were effective on 5/1/2024. There's all kinds of information out there as far as, and I can share that with you. There's, you know, there's webinars and recordings and provider letters. So I'm not sure exactly how to answer that question.
I think that's just been a standing update that Pam's provided in terms of what flexibilities were ending, what flexibilities were continuing, what was becoming permanent.
Let me see if I can, I'll try to put this in just for your information, Emily, and you probably already have this, but I'll go ahead and put it in the chat if I can.
And I know that this is something that you've recently taken over. So if you want to wait until August to give us more of an update.
Oh, that'll be fine too.
Yeah. Next up, we have an update on any housing meetings that have happened between DMS and the Kentucky Housing Corporation.
Oh, I didn't see that one, so I believe that's gonna be me then. Sorry, I missed that one. So we currently have a regular standing meeting with the secretary, and we call it our Health and Housing Collaborative. And it really started when we were thinking about how to come up with a housing component, like kind of like what we've added into the 1915 I, and we just kind of continued forward with that. Since that time period, our collaborations have gotten stronger. They've written additional grants that could support Kentucky. We've given support letters to help them along the way. DBH has also, supported them in their grant opportunities that they've applied for. We just recently also, with all of our collaborations, were able to get 25 additional HUD slots for MFP. And I don't think we've had those for quite a while. We used to get those back when I was in Pam's position a long time ago. And so we were very excited to see that collaboration again and get 25 slots or HUD vouchers, not slots, for our MFP clients. So as you're aware, HUD vouchers are hard to come by sometimes, and a lot of folks are trying to get the same housing. There's a lot of competition for housing.
Oh, yeah, yeah. Can you tell, what's the client, the MMP clients, what was that?
Oh, money follows the person.
Oh, yes, I'm
Yeah.
familiar with that. Okay, thanks.
Oh, and I was going to mention that as well, Emily. You and I have talked about this before. There is a possibility now that we are working on this 1115 SMI, that once we get that waiver approved, then we can go back and update the operational protocol in Money Follows the Person, so that that could be a population that could be moved out from IMDs. So this is exciting, because I'm not, this has probably been 20 years ago, 15 years ago at least, that we asked CMS if we could assist with moving folks out from IMD locations. So that's kind of interesting. That's more to come as well, but we'll have to request an operational protocol change to our MFP program.
Okay, yeah, that's the first I've heard of that. So thank you
Yeah.
for sharing.
If this is too in the weeds, that's okay, but can you explain Money Follows the Person?
Money Follows the Person is set up to allow folks to transition out of nursing facilities and other types of facilities that can live into the community. So Money Follows the Person can begin case management, assisting with rolling them out. There's special funds, and I've not been in this program for a while as far as financial information. They stay under the MFP demonstration grant for 1 year through day 365, and after day 365, we're required to say they have a transition plan. And what that transition plan can be is actually a waiver, but we have to earmark slots. So if you've heard Pam or others talk about there's 17 reserve slots for MFP and ABI. And what that is folks that we've moved out from nursing facilities or other types of facilities that meet that criteria. They can be eligible to move into the waiver after day 365. Does that make sense? But we need a slot for them. So we had to prove to CMS we had a plan for them to get CMS to agree to that. We had to show that we had a plan, so we had to reserve the slot. So I know we get questions about why are those slots reserved sometime, but it's usually just a handful. I think there's like 17 maybe in ABI, and it's just a handful. Does that make sense? And I can give you more information about Money Follows the Person. It's been around a really long time. Kentucky does a really good job with it. And we've got statistics. When it was new back, 10 years ago, folks ask about it all the time.
Okay, thank you.
Yes,
Yeah,
ma'am.
that's good background to have. All
And
right.
Emily,
Yeah.
there was a legislative housing commission created with the last session, and they had their first meeting earlier I think this month or the last of June, and they had Wendy Smith with the Kentucky Housing Corporation just to come in and brief the legislators, about specifics regarding housing and the work that they do. So I think there'll be more information coming forward that we might be interested in following once they have additional meetings.
Yeah, I'm glad you brought that up, Melanie. I missed that meeting. I was in another meeting, but It is something that we're going to try to monitor over the interim session. And I am curious to know if DMS is going to be at all involved in that. I know housing is generally outside of, the Medicaid wheelhouse, and yet we've started to see it, becoming more and more part of the conversation in terms of being a health-related social need. Obviously, with this SMI waiver, housing is a component. So, oh, and Justin, thank you. It sounds like there's going to be an agenda with disability and homelessness specifically on the agenda. So that's good to know.
Emily, were you talking about an upcoming conference that was coming up? I know.
No, the housing task force.
Oh, I'm sorry.
The legislature is holding.
Housing has an upcoming conference going on, and I know Jody's been working with them and developing some slides to embed into their presentation.
Okay. Thanks for that. I think it'd be good to see those slides. So if you all don't mind sharing them whenever they're available. Are we ready to move on? Is there anything else that people want to discuss related to housing? We've covered the surveys. So the next item here would be the network adequacy issue reporting process for Medicaid members. And is there an updated draft of the access to services form that we could take a look at? That's usually been something that Angie Parker shares. Is Angie on? I haven't seen her yet, but I haven't scrolled through the participant list recently. Doesn't look like it.
I believe she's having issues with her audio and the speaker, but she's
Oh,
trying.
there. Yep, I see Angie there now.
I'm gonna say we can get it back to you if she's not able to get on.
Yes.
Can you hear me now? Can you hear me?
I see you now.
Yes.
I think we heard you. Yeah.
I think I heard her.
Can you hear me?
Yes.
Yes.
I've got a different thing on today, and apparently I hit the wrong button. Okay, so the network adequacy, when we worked on it the last meeting, wasn't that April? We kind of did all the changes then, and then it was sent back out. You all should have gotten it like right after that last meeting to see whether or not there's anything else you wanted to add or change.
It's been a while since then. I think, was that meeting right before or right after the session ended?
I think April 16th or something like that.
Yeah, the day after, which is great timing on our part. And was it you, Angie, or Aaron who sent it out?
Aaron, I believe. Yeah.
Mm-hmm. I thought that we either had, gone back and forth over email, or maybe I'm remembering the last.
During the meeting, we kind of
I
highlighted
do remember that
made
too.
changes and then sent it to Aaron to send out. So hopefully you got it. If not, I can resend it.
I see something on.
Oh, sorry, I was looking through my emails in your old folder. Is it the member
I
access
see
to
something on May
service
2nd.
draft?
Is that?
Yeah, it would have been.
May 2nd?
Yeah, because I had to look back to see what date that we did it to make sure if you needed to see it again that I could pull it up. But
yeah, would you mind just pulling it up? We can take a quick look at it. I do think that might have been something that got lost in people's inboxes.
Okay, and Aaron, if you can give me the ability to share, please, ma'am. I already did. All right. Here we go. All right. So we initially had this down to like one sentence. Then we added a lot more. Just to give an overview. I mean, it's when you all sign off of it, we take draft off of it, and you can share it with whomever, and then we can work on getting it on our website too for easy use, but we don't have that at this point.
Okay. That's all good to know, but yeah, let's just scroll down. I think where we had asked for some changes was in
I believe this is the first paragraph.
Well, yes, that first paragraph, and then what provider somebody's reached out to, or
Yeah,
a little
I
bit
think we
more
took
about how
some,
they
yeah,
described
yeah, I
what
think we took
service
that
they
out.
needed.
We
Okay.
took that out.
So the appointment dates offered, that one, I would say if, and, or at least have the option of none. I mean, there could be a provider that says that they don't have, or they were not able to get in touch with any provider. Like, what if there's no psychologist in their area and, you know, they're looking
Okay.
for a psychologist, but they haven't actually been able to connect with one? Just as an example, because I know psychologists are few and far between.
They say if yes, please enter. I would say below, but it's not below. Or is this necessary?
Even, I think appointments dates offered is a fine question, but then one of the answer options could just be no dates or no availability. Just so that it's not, you know, something that they'd have to fill in and can't fill it in. And then if there's no appointment date accepted by the member, I think you need to provide another option for that too. Just as you're thinking through how people will fill this out, I want to make sure that people are able to submit the form, and make sure that they can, you know, complete it, even if they don't have a date, that they can still submit the form, so that it's not like a required field that will stop them. And I think otherwise, it looks like it looks ready to go to me. Miranda or others, do you have thoughts?
The date of first request for appointment, that means the date on which you first said, hey, I want an appointment.
Mm-hmm. I mean, any of this can be taken out or changed, as you can see.
Maybe I
think
I was just thinking about rewording it to make it more obvious that that's what you're asking for. Like date on which you or the patient request. I don't know.
Yeah,
if
was it
what
when
you
somebody
want.
made a call for the appointment, or when they wanted to have the appointment? I guess that's a good appointment requested. That's much more clear.
I mean, I don't know if it's much more clear. It makes me have the same question, appointment request date.
Well, how about if it was, when did you request the appointment? When did you
Yeah.
first request the appointment?
Well, I mean, that could be, I called today, but I wanted it tomorrow.
Well, that's a valid answer. It doesn't mean that might not meet network adequacy standards, but
Do you all see these
it
green lines?
might not mean that it's outside of network adequacy standards. But
Yeah, I see the green lines.
I don't know what that's causing that. Okay, so appointment request date, when did you want an appointment? Well, I'll work on the language on that to simplify. If you think it's relevant.
I mean, I guess the question, are you asking if it's a relevant question? Like, do we need to know the date they requested an appointment?
Yeah.
Well, I think if oh, this is funny.
What is going on? I mean, I'm not doing anything.
Book and checks or something. If you're trying to determine if the appointment was requested and then dates were offered within the time frame that would meet network adequacy, I think you want to, you know, identify that.
Yeah.
Another way to ask is just, you know,
Angie, please stop sharing.
Yeah.
Want me to stop
Yes.
sharing? Okay. Thank you.
Yeah, that's just weird. Okay, so I'll work on that. Send it, I'll give it back to Aaron. You all can look to see whether or not that's
Okay.
something that you would like to, if you like the language that you would. And then we'll finalize it.
I think dates you attempted is a good way to put it too, because sometimes people can't get through, or they, didn't necessarily get a specific appointment at that time. So I'm good with that.
I like that as well. And I don't think that it was sent back out after the last meeting.
Well, I did see something in like May. Whatever happened, it happens. Sometimes we miss things, but I appreciate you all making some adjustments to it. And I feel like we're close to having something that can be shared. And I really do hope that we can also have an online version pretty quickly, because most people aren't going to fill out that form, but a few will. A few who are in a really, difficult situation probably will. And hopefully once we have an online form, we can get other people to complete it without it taking too much time. So.
Well, I mean, at the very least, we might be able to put it, if we don't have a drop down and all that stuff, fill it out, and then you can just email it directly from there.
Yeah.
So that we can look at that.
As long as people don't have to have like an Adobe sort of, an Adobe account, or subscription to do it, I think then it shouldn't be too prohibitive. But I know with some of those fillable forms, it just varies. So just keep that in mind. If you can set it up in a way that it's open and people don't have to have that kind of access to their own software.
I'll have my tech people looking at that, because that'll be
I
for
keep
ease of
thinking
use.
I keep thinking back to the presumptive eligibility form that you all had online, because that really worked out very, very well.
Okay.
It doesn't have to be anything fancier than that.
All right.
All right, so our next item here is alignment of quality initiatives. I know that's kind of a goal of the cabinets. Just wanted to know where you all are at in the process.
Well, I have something to show you what all the measures are, but I'm afraid to share it.
Well, understandably.
Andrew, go ahead and give it a try, and it just immediately take it down if we start to incur problems.
I mean, it did look like a kid. At least there was nothing.
Okay, so what I've done here is we have the HRIP, and then we have with UK U of L, and then the managed care value-based purchasing program, and what those measures are, and how they are alike. I did have a legend on here. I don't know what happened to it. But basically green looks like all three have those particular measures. Yellow are between HRIP and UK and U of L. And orange is between UK and MCOs. So as far as, I don't know what happened with all the colors on this, but I can certainly update it for easier.
I just want to make sure you have restrict the editing on stuff on the Word document. Actually, real quick.
Okay.
Okay. Any questions about this?
I think I am curious about the color coding. I mean, green seems like it's probably doing better, but
well, no, green means that all three have that same measure. All three of these.
That's
have
like
that quality measure. Yellow means
alignment.
HRIP and UK align, and orange means UK, U of L, and MCO BBP align.
It is nice to see it all in one place. When will you have like the actual data in terms of performance?
Well, as far as HRIP, we showed the 2022 here, right? Yes, yes. I've shown it. It's one. Oh my goodness. Okay. I'm quitting this
Happening
now.
again.
I'm trying to scroll through. Some of our participants have some interesting names, and so I'm trying to remove some people from the meeting. So I do apologize. I think something wonky's going on, so I'm working on removing a few people from the meeting. I'm so sorry, guys.
Thank you, Erin. And now
I'm not going to share my agenda for a minute because I'm scared to. So Emily, if you want to proceed, I'm going to work on removing the improper named
Understood. Yes,
participants.
yes. I can handle this. Okay, our next, I don't know, Angie, did you have more to say about the quality initiative?
Oh, no, I
Okay.
don't. I will get that cleaned up for you where it's and have my legend on there so you'll know what I'm talking
Okay.
about and
Well,
send that to Aaron. And then as
yeah,
far as
that sounds
results,
good. I'd love
we
to just
finished the A
know,
trip.
you know,
Yes.
for every measure, how many of the hospitals are meeting that? How many are, you know, close, working on
Okay.
it, whatever the case is.
Okay. So it wasn't this TAC, it was hospital tax. I need to turn the chat off, seeing some of those names. Anyway, yes, I have that for the A trip for 2022.
I don't think we've ever
That
had
I can no, that I can show you. I can show you at the next meeting. So if you want to put that on the agenda.
Yes. Okay, A trip measure
2022 results.
At next August meeting.
Okay.
Oh, great. School Medicaid is our next item here. And I just have to say congratulations to DMS for being selected as one of, is it 20 states for a school Medicaid grant from CMS. But really the achievement is much greater because there were, I think we were in the top tier or like the most narrow bucket, I should say, right? 3 states were selected for the grant that Kentucky
They had
received.
a total of 20 grants that they were going to give, and they only awarded 18. So yes, we did a fantastic job and are very excited.
Yeah, well, we're excited too, because I think there's a lot of interest here and a lot of opportunity to provide more services to kids in schools, and just really wanted to know, you know, how this is going to get started, how, you know, you might involve stakeholders in the process. And
I think I'll leave.
Commissioner, thanks for joining us.
Yeah, I just, had heard this was a really good TAC to join. So I was a little bit
Were
busy.
you here
Sorry.
for some of the
Well, just on the
tail
end, and that's one. So, no pun intended there. So I think Erica, I will leave it up to you to talk about some of the great opportunities that we have with the 2.5 million that we have been awarded for the school-based services grant.
Certainly. So with that, we are the period began July 1. So we are meeting this week internally just to go over the timeline and deliverables. And then we will be having some really intense meetings coming forward with our advisory group with that grant. And then as far as where we are currently for school-based services, and I know, Emily, you had asked before about the IEP services versus expanded access. So we do have some of that information. So the IEP services, those are the ones that the schools are most comfortable with because they've been doing them for quite a while. And so our numbers are much higher. But I will say from fiscal year 2020 through 2021, so I guess 2-3 school years ago, it was approximately $2 million in IEP service claims. The past school year, it was over 7 million. And so that is an increase of 284.4% for the IEP services. So we're seeing that those are being utilized a lot more. And then for our expanded access, that was rolled out for the 2020 school year. Of course, we had COVID, so a lot of schools weren't in session when we didn't see the uptake in that as which was expected. So the first robust, or not robust, but the first year where schools could actually participate was 2021 through 2022. And we only had $93,739 in claims. The following school year, we had over 253,000. So that's an increase of 170.35. We anticipate for this past school year, we're pulling the numbers now, so that ended June 30th. So we'll have those numbers soon. But we are expecting that to have grown again.
Good. Yeah, it's definitely going in the right direction. I'm curious about IEP services. I have to say, one, I would have thought that they would have actually been higher than that. But that growth that you shared, do you attribute that more to schools billing Medicaid for services that they were otherwise just covering through their own budgets before, or actually offering more services to their students?
That's a good question. I can't really say, but that's something that we could look into, because I know that there have been more IEPs and 504s that have been issued for students. So it could be that more of those services are being identified.
Being requested, or yeah. And then I think in an email exchange, we had talked about the difference between like the fee-for-service claims versus the administrative, payment that schools get. Do you have kind of an estimate about how much more schools are bringing in if you were to combine what they get fee-for-service plus the administrative rate? Is it like 20% more? Is it 30% more? What?
I'm not sure if Commissioner Lee has a better guess.
Just as a ballpark. I mean, I'm not looking for anything like really specific.
I'm sorry, what was the question?
On administrative claims, how much more that would bring in for the schools? I wanted to say it was 30% or more, but
yeah, I think it would definitely depend on the level of effort that the schools undertook to expand those new services. I think, I don't know if I'd even want to ballpark Emily, but maybe, under like Erica said, maybe it would definitely probably be under 30%. But again, if they undertook a lot of efforts, because the administrative claiming is for outreach and other activities related to Medicaid, and it would also be dependent upon how accurate they were with their random moment time study.
Right. Yeah, I figured maybe there'd be a range, but oh, here it comes again.
So have we been hacked, or is that? Can we tell exactly who's doing that?
I'm trying. I keep scrolling, looking for the names of people that don't seem to belong, and before I'm getting to them, but I haven't let anybody else into the meeting. So I'm looking into that, Commissioner. I'm so sorry, guys.
And is there, I mean, this is being recorded, so if there's a way that we could definitely find out who all called in and where the numbers came from, maybe we could find out. And I would just like to state to this individual that, what we're doing here, we're conducting official state business. We are, the topics that we're talking about are very critical to improving the lives of those we serve. And that's 1.5 million members in the department that the Department for Medicaid serves. And while I appreciate, I guess, your creativity, I wish you would take this just a little bit more serious if you would like to participate in our events that have an overall impact on the health and well-being of 1.5 million individuals. And so, Emily, turn it back to you.
All right. Thank you for that. And I think, if as more information comes out, as you all have more of a plan, opportunities for stakeholder input, just if you could keep us kind of posted on that. And, we're just really looking forward to finding ways to help spread the word about school Medicaid, get more families interested, of course, more schools participating too. I know it's a mix of factors, right? You need the workforce, you need the schools to be on board, you need the the random moment time study and the claims to work, and then you need parents to agree for to have their kids receive those services. So thank you for all the work that you all have done on that. We really appreciate how you prioritized it.
And we'll definitely keep this TAC and definitely the MAC involved in work plans and what we're doing in activities. Again, school-based services, schools are where our kids are. If we can get as many services to them in that setting as possible, I think that will make a huge difference in the lives of over half of Kentucky's children that are enrolled in the Medicaid program. So definitely want to have all input that we can to make sure that we roll everything out in a positive manner and in a way that gets input from all of those that whose voices really matter.
Yeah. Thank you. We're here for it. So our next item here is language access, which is something that we've discussed the last many meetings. I know that the cabinet, you've been working on a decision tree, and then there's been some discussion about making some specific recommendations around different populations and having the supports in place for them. So is there a decision tree to share yet?
Well, I have a one pager, but I'm not sharing anything
I think at this point we've learned our
but
lesson.
regardless of that, it's been a very, just to say, it's been a challenge trying to make this an easy communication on how to get language interpretation. We've got the information from the MCOs. We're going back and looking at what they're doing and how they're providing that information and how we can simplify that. Because after we got that and have dug into some of the processes, such as calling, it's there's not easy access that way. So we're looking at how that can be simplified.
I feel like we have at some point discussed having one call-in number that is, a language service number that would be the outbound, like it would be the inbound number. It'd be what the public would be calling if they knew they needed language access services, rather than calling DCBS or the MCO first, and then being able to be transferred or connected to DCBS or to, an MCO perhaps from the language line. Is that something that you all are considering?
We've looked into that. Of
It's
course,
sort of a
there is
one door is basically what I have in mind. One door, one number.
We have looked into the possibility of that. Of course, there is a cost to that and how that would be, managed as well, as far as that is concerned. Like I said, it's been a little bit more challenging than anticipated. I'm trying to come up with, I agree that one number would probably help a lot, but then you also have to have oversight of that and, as I said, pay for it. But it's still a work in progress, and how we can initially start something that to ease the process in getting language access and interpreters, but we're not there yet.
But when people do call in to the DCBS line or any state line, there is still the option for language access.
Yes, there is.
To me, it's more of an order of things, right? Going directly through language access to get to the cabinet versus going to the cabinet to get to language access. So Miranda and Arthur and Brenda, I feel like we all have talked about different populations that we want to make some sort of recommendation around. And I know you all have been giving that some thought. Do you want to make any recommendations around these particular people who speak different languages, people who are deaf or hard of hearing, speech impairment, nonverbal? Are you ready for that today?
I had drafted some recommendations regarding spoken languages, but was kind of wanting to have just a better understanding of how things work before making them. I have several. Maybe I should put them in the chat.
Well, I wonder if maybe waiting on this decision tree is not, if it's complicated and you're kind of running into various, issues, Angie, maybe we could have a presentation about what the language access services are for these different populations, whether it's from, DMS, from the MCO,
Well,
or
we have,
provider.
I mean, we have what the MCOs do. We know what DMS, or I should say the
Right.
cabinet does as far as language access. So if I were a Spanish speaking person and I called into Medicaid, I would be able to get an interpreter. They'd be able to get somebody on the line. And then if, TTY, that's in place. And there's some, and I will use Danita Coulter's word. There are barriers to how we are able to get all this information into a decision tree or a one pager. But
I don't want the
believe me,
decision tree to stop us though from getting from the TAC, from just better understanding what the current process is for these 4 populations. So maybe at our August meeting, you could just kind of present to us, this is how it currently works.
Okay.
If somebody is either reaching out to the cabinet or reaching out to their MCO. And then that could fill in some of the gaps that I think Miranda has in understanding what the process is, so that we can make some good recommendations. And maybe we can troubleshoot, this decision tree one pager by having all that information kind of presented to us.
It'd be very helpful, Miranda, if you can kind of give me or send me your ideas of the language issues that you're talking about. I think we could look into, maybe we might be able to address some of that with this discussion in August too, before then, if I can.
I mean, essentially what I have heard on the ground is that sometimes patients are told that they need to coordinate getting an interpreter themselves through their MCO rather than their medical provider providing that for them, which doesn't seem right.
Well,
and then
medical providers are federally required to have interpreters, as you know. So, but there are within MCOs, they also have that assistance that you can call in to their member services line, or the provider can call in as well to get assistance.
I think the onus is on the provider to offer it. Now, I understand from a provider perspective too, that it's cost prohibitive at times, but even if the MCO is offering some sort of assistance, I think that onus should be on the provider to coordinate that, not for the individual, and to do it in, a timely manner so that it's not like a delay in care.
And that is one of the things. There's a couple of MCOs, they have a form that the provider can fill out, or the member for that matter. But they have to get it to them a few days ahead of time if they want that person with them at the doctor's appointment. So they can offer those services. There are a few MCOs that offer those services, that they can have an interpreter there with them in the doctor's office, but they need some lead time.
Right.
So it could be the provider filling out that form if they know it, that, ahead of time, or the member could do that. They know it,
So when we had brought this up before, one of the things that we talked about, I think someone from DMS, maybe Veronica, had said that there would be a letter sent to providers to clarify the provider's responsibility to offer interpretive services for spoken languages or sign language. And so I don't know if that's already been done, because that was one of the first recommendations on my list.
Oh, okay. I don't remember that. It might. I'm pretty sure that hasn't been done.
Maybe that's a recommendation we can go ahead and make then.
A letter to providers clarifying
their responsibility to offer interpretive, or offer and provide interpretive services for spoken or sign language.
Offer, coordinate, and provide.
There we go.
And this is Melanie, it's possible to have it done in plain language, so that a wide range of individuals would be able to understand.
Yes, that's a very good point.
Well, I mean, and it has to be somebody who can interpret medical.
Oh, yeah. I mean, it should be
certified person.
It should be a qualified interpreter. Through,
I mean, I might be able to speak language. I mean, Spanish. Well, I can't, but if I could, that doesn't mean I can actually
qualified medical interpreter.
effectively interpret medical terms in Spanish.
Melanie, were you talking about the interpretation itself or the notice to providers?
I would say, well, both, to be honest. I mean, because it's just putting things out there so that people understand what the expectations are. Because I remember when I worked at UK Developmental Peds, that there were some amazing interpreters, and we always were responsible for kind of helping to facilitate that individual to be present. But oftentimes after the initial appointment, it would be my job to work with the interpreters to make sure that they were there. And I always felt like we had a good system, but I always wish that there was information being put out there that was helping the patient to understand things that can sometimes be a complicated process, and having things in plain language and granted, I worked with a very different population of individuals, but it just helped to make sure that people truly did understand.
Yeah. No, I think, I know we're not at recommendations yet, but I think we can say something to the effect of that DMS send a letter to providers clarifying their responsibility to offer, coordinate, and provide language access services via a qualified medical interpreter, and that providers should communicate the availability of language services to their patients in plain language. But we can get back to that. I think that's a good next step. And then Angie, if you can just do a presentation for us at the next meeting where you help us see how the process currently works for those different populations, I think that would be helpful.
Yes, that'd be really helpful.
Okay. So then our new business, that's where we're at now on the agenda, would be well, three things. I'll start with the first: new federal rules for managed care and for eligibility and enrollment. So these are CMS rules that will make some changes to how Kentucky is I think operating managed care, overseeing managed care, and then also eligibility and enrollment. Is there anything just high level that you all are kind of planning for or working on in terms of changes based on these new rules?
Well, they're I don't know who's on here. I don't know if anybody higher up than me is on here or not, but I do know that we know about these final rules and that they are being evaluated. Okay. And to see, looking at the timelines for those and how to make sure that we are implementing them timely.
Okay. Maybe this can be, an August update too, but two things that stood out to me. I mean, there's a lot in them and I didn't read them word for word. I definitely looked at some cliff notes, but one thing was around network adequacy, and one area where I think CMS is really trying to improve how managed care is operating and making sure that we have adequate networks. And the thing that I keep coming back to is how we're measuring our networks to begin with, and just really looking at the capacity of the providers who are, participating in Medicaid and are also, serving different regions of the state, and just being able to better measure what their capacity is, how many patients they're seeing. I know you all have been looking at claims data, what's being billed, but if we can, really kind of continue working in that area. And then, of course, you don't have the claims data for the areas that don't have, you know, providers billing. And that's a whole other way that we need to be measuring network adequacy, where there are gaps. But that's just one thing that stood out, that there's quite a bit around network adequacy. And then I saw something around bad addresses too, or, you know, essentially return mail that could either lead to coverage being suspended or terminated. And one of the options that CMS seems to be giving states is that rather than suspending, rather than terminating, that individual or that household could be transitioned to fee for service, so that you're not continuing to pay a per member per month while you're trying to find, you know, a better address for the individual, but that their coverage isn't, you know, cut off either. And I'm curious to know if that's something that you all are considering, and also would just encourage it, because I think it could be helpful for some amount of time, not indefinitely, but, you know, as an opportunity to get a better address for that household.
Like I said, there's as you know, you read the Cliff Notes, and there is a lot with the plan roles, and we will be looking at each and every one of them and how to implement them. You mentioned network adequacy. Of course, you know, that's in my area. I've looked a little bit more in depth at that one myself. And as you already know, we are trying to ensure that what is being reported is actually an adequate network. We also know there are challenges with the network in general in certain areas, and how, because they don't have people or providers in that area, then how do we address that?
Yeah.
One of the challenges that I noticed with the plan role is being able to get an appointment within 10 days, whereas for a regular appointment, which now it's 30 days, that's going to be a challenge. So, you know, again, we are reviewing the plan rules, the final rules, and figuring out, and you know, we have a timeline. We've got to see what is due when, but
This is
I don't
Leslie.
think we don't have anything definitive at this moment.
Angie, I just would offer this up too. So we're taking this very serious. It can affect several areas. Commissioner Lee is taking it on to ensure that we have someone to help us to ensure that we meet all the timelines and all the areas that are going to need changes. It's not just going to be one area. So I just wanted to share that with you. Commissioner Lee did just recently share, you know, with CMS about, you know, what things would help states, because all of the states are in a very similar situation. We've all got lots of 1115s, 1915 Is, and all other kinds of initiatives coming out of COVID, and then add upon this many federal rules. So she had suggested that maybe they could help, you know, develop templates and things like that that could assist states in ensuring that we had all the checkoffs, if that makes sense. So I thought that
it was a lot
good
back to
idea.
back, I have to say.
It is, and we participated in the last Southern NAMID conference, and all the states sounded just like us. From us to the Virgin Islands, we're all sounded just like us. Like, how can we get all this done? We want to make sure that we do it correctly. We want to make sure we do it efficiently and not have to redo things. And so she had made that suggestion. As you're aware, she's the NAMID president, and made the suggestion for some templates or some checkoff boxes to ensure that we don't miss anything.
Yeah, that does sound helpful. All right. Well, we can revisit this as, you know, we go with our meetings, and see where you all are at with making some of those changes. But if there is an opportunity to have input into certain changes, I think that would be helpful too. The next item here is one that we've been sort of waiting on. So Arthur, are you ready to, I think you said you actually were going to have a guest come to talk about a proposal to overhaul the Michelle P. waiver and other waivers. Is that something you want to keep on the agenda, or do you have your guest here today?
I. They. They keep. They keep putting him off. You can either you can either keep on keep it. Oh, you can either keep it on.
We can keep it on the agenda. Yeah.
I'll take it off.
Okay. Yeah, no, there's really no problem with keeping it on the agenda. So just, let me know when you have a guest that's ready to speak on it. And if there's nothing else on that topic for today, our next one is dental services data request, which I had sent to Aaron maybe a couple of weeks ago. So I'm not sure if you all have had a chance to pull that data yet, but just wanted to ask if there was anything you could share today.
I have submitted that, Emily. This is Erin, sorry. I've submitted that. It's due back to me next week. And once I get it, I send it up to upper management for review before sending it out to the TAC. Typically with data requests, we ask for 90 days to make sure we can have time to gather everything, have it reviewed and get it to you. But it typically doesn't take 90 days, but you should have it hopefully in the next few weeks.
Okay, thank you. That's good to know. And then we're on to general discussion. Is there anything that we haven't touched on yet that people want to raise in this meeting? Questions or concerns, thoughts? We can go ahead and make our recommendations. I have the recommendation that we discussed previously about providing a letter to providers about language access. So I'll read that again and ask for any changes to it. And then we can also go ahead and get a motion to approve if people are happy with the language. So the recommendation would be that DMS send a letter to providers clarifying their responsibility to offer, coordinate, and provide language access services via a qualified medical interpreter. Providers should communicate the availability of language services to their patients in plain language. I guess I should say, and that providers should communicate. Any changes to that language?
That sounds good.
Okay, thanks. I'll take a motion then to approve that recommendation.
Motion.
Was that you, Miranda? And then Melanie, okay.
Second.
Thank you. I saw your little boxes light up, but I couldn't tell who was first, second. All right, all in favor say aye.
Aye.
Any opposed? All right, motion carries. Thank you all. And then I had a recommendation to kind of run by you all related to the birth certificate issue. And that recommendation would be that DMS work with DCBS and the Office for Vital Statistics to clarify that Kentucky birth certificates should be acquired internally and not require action on the part of the household or individual. Does that sound like the clear language?
Sounds good.
Okay.
Yes.
Then I'll ask for a motion to approve that recommendation. Thank you, Arthur. And a second?
Second.
Thanks, Melanie. All in favor, say aye.
Aye.
Aye. Any opposed? All right, motion carries. Thank you all. Miranda, did you want to do a recommendation around connector language search, or do you want to kind of think on that? I know it could be addressed on the monthly meeting too, that David mentioned.
Yeah, he mentioned the monthly meeting and the Friday, whatever the Friday email that goes out to connectors is called. I'm blanking.
The Friday facts.
Thank you. Yes, alliterative Friday facts. So that's great. I do not have further. I mean, I think it should be. Granted, I haven't gone back to look at what the onboarding connector materials say about putting in your language or not. If it's not in there, it should be, but I
Oh, yeah,
yeah.
we're gonna develop a one-page cheat sheet that we can send out to people. I know I would need one, so.
I mean, something that's part of the onboarding packet for connectors.
Yeah, yep.
Okay.
Yeah.
Absolutely. Yes,
Well,
ma'am.
Miranda, do you want to give us some more thought and we can revisit in August?
Sure.
Okay. And then I have one other that I've been kind of kicking around, and I don't know if it's premature to do this or not, but my recommendation would be related to the bad address policy. That DMS update their bad address policy to move individuals or households that are non-responsive to fee-for-service for up to 6 months or until an updated address is received. The current process is that people are suspended and then terminated, coverage is terminated, but in any event can't use that coverage. And we know how often people move and, you know, their addresses just kind of lag in terms of getting updated. It's kind of been a chronic problem.
Yeah, I think that's a good idea.
Yeah,
So you
same
said
here.
Was that you, Brenda?
Yeah.
Yeah. Miranda, were you asking a question?
Yeah, so just to clarify, to make sure I heard it right. So you said to move them to fee-for-service for 6 months or until a new address is received?
Yeah, up to 6 months. I mean, I don't think it has to be like always a solid 6 months, but obviously you can't keep somebody on indefinitely. But I think up to 6 months or until a new address is received.
Thanks. Sounds good.
Okay.
Yeah.
And, you know, we'll see what DMS says about it, but I think it's knowing that this is something that CMS allows for, I think it's something worth exploring. So I'll just read it again and then ask for a motion. DMS update their bad address policy to move individuals or households that are non-responsive to fee-for-service for up to 6 months or until an updated address is received. I'll ask for a motion to approve that recommendation.
So moved.
Thank you, Brenda. And a second.
Second.
I think Miranda might have beat you.
Yeah, I think so.
All right. All in favor, say aye.
Aye.
Aye. Any opposed? Motion carries. All right. Any other recommendations that you all would like to put forward? Okay. Hearing none, I'm going to assume that we can, you know, revisit some of the things that we've talked about today. I know you have some, we're giving some thought to certain topics, and maybe we can make those recommendations next month. I'll be the person to represent our TAC at the MAC meeting. And then our next TAC meeting will be on August 20th at 1:30. And with that, do I ever take a motion to adjourn? Adjourn by acclamation. We'll adjourn by acclamation. I think given today's antics, that's acceptable. So, all right. Well, good to see everybody. I'm glad we were able to conduct business with all the things that were going on. And Erin, appreciate your help with all of that too. Thank you.
I apologize. And
you kept the meeting on track.
You were amazing.
Well, I'm flustered over here on this side, and so thank you. We will get to the bottom of trying to figure out what's going on and try to keep some of those things from happening in the future. That was a first for me.
Yeah, same here.
I will monitor names better as well. So anything that looks odd, if your name is not on there, you might not get into the meetings moving forward.
Yeah. I often wonder about numbers, but
Bye.
we were able to get through the agenda, and I appreciate everybody for being here. So thank you very much, and we'll see you next month.
Okay, goodbye.
Okay, bye.
Thank you. Good job, Erin, being diligent. Bye.
Thanks, Miranda.